Hello, good afternoon. I think we have our facilitator with us, and without wasting much time, let me introduce our facilitator, then we set the ball rolling. Before that, you are welcome to Icona Health and Research Consult. We would advise that we all try as much as possible to follow the page, subscribe, so that you stay up to date with whatever information we share on our YouTube channel. So our facilitator for this Zoom meeting afternoon is in the person of Dr. Nabil Huwaj. And with a little background about him, he's a medical entrepreneur and an experienced consultant physiotherapist. Sorry for the interruption. He's a dedicated medical entrepreneur and an experienced consultant physiotherapist with a passion in improving patient outcomes and delivering quality care. He also has a strong background in managing patients with musculoskeletal and neurological conditions in the tertiary care hospital. His area of expertise lies in manual therapy. He's also a certified orthopedic manual therapist from the UK, and he has strong commitment in staying at the forefront as far as the practice of physiotherapy is concerned. In brief, our facilitator is the head of rehabilitation departments at the Al Khalij Hospital in Pakistan. He is also a doctor of physical therapist. Like I said earlier on, he's a certified orthopedic manual therapist and the founder of AutoCare Physiotherapy Consults. Without wasting much time, I'll hand over to our facilitator for this program. Thank you. Dr. Nabil, I think you can unmute your mic. Your microphone is still muted. We can't hear you. If you can hear me, Dr. Huaj, your microphone is still muted. You have to unmute so that we can hear you. Ladies and gentlemen, let's continue to keep our calm as we work on connecting our facilitator. Okay, I think our facilitator has unmuted now. Without wasting much time, we will hand over the microphone to him so that we can set the ball rolling. You are welcome. We are happy to meet you, Dr. Huaj. Hello, Dr. Huaj, can you hear me? Colleagues of the noble profession, let's exercise patience as we try to connect with our facilitator. I learned he is having a technical issue at his end. Please let's stick and stay as he try to connect. Thank you.
Hi, Doc. Can you hear me? Hi. You are still not audible. Can you check your microphone?
To connect with our facilitator. I learned he
Hello, PT Michael. I don't seem to hear anything, guys.
Yeah, PT, you are audible. We are
All
having a
right, all right.
challenge with our facilitator connecting. I think
Okay.
we have it
Okay.
now.
Okay.
Am I audible to you
All
guys
right.
now?
Thank you.
Yes, you are audible. We can hear you now.
Okay. 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 So, hello everyone. Well, you guys, and also I'm very thankful to my brother Michael who invited me. I will try to not take much time of you guys because it is my first interaction with the time. I'll share my video. Just a second. Yes. Can you see my screen?
Yes, please. We can see your screen.
So today's my topic is understanding sciatica and low back pain. I will try to keep it short because it's a bigger topic. It's a very wide topic. If I had to write about it, it would take almost a week writing about sciatica and lower back pain because there are hundreds of reasons of which because of sciatica and lower back pain could happen. So first of all, I would like to tell something about myself. My name is Dr. Nabil Khwaja, as you all know. I'm head of rehabilitation department at a college hospital. Also, I've done my degree of DPT, Doctor of Physical Therapy, at Jauddin College of Rehabilitation Sciences. I am orthopedic manual therapy certified. Also, I'm HCPC registered. I'm a founder of this orthocare physiotherapy, which I'll tell you later about. Also, I'm a consultant musculoskeletal physiotherapist at Health and Services at Karachi, Pakistan. So, if I'm audible, I'd like to tell you that what would we be discussing in this whole presentation and whole webinar. The things I would like to discuss with you would be, first of all, the lumbar anatomy, what kind of joint a lumbar vertebra is. Also, a simple anatomy of short anatomy of sciatic nerve. Also, the presentation of sciatica syndrome. If sciatica syndromes happen to a person, how does it present to physiotherapists, or how does a patient feel while having sciatica? The secondly, we would be discussing biomechanical assessment, in which we'll be discussing the muscular element, the pelvic tilting element in it. Then we will be discussing elements contributing to lower back pain, which would be some muscles that could cause low back pain, some lack of control in muscles, which can cause low back pain. Also, after that, we'll be discussing the treatment strategies, how we can differentially uh, treat without going with the traditional treatment. At last, we have a Q&A session, question answer session. So uh, related to any therapeutics, you can ask any question if you have any query if you have at the last of this session. So starting from the sciatica, as you know that sciatica is a chronic pain condition that causes due to the compression or irritation of sciatic nerve, which is most common cause of low back pain and leg pain. It refers to your leg, and mostly 30 to 50 age group of people are mostly affected. According to Medical News Today report, up to 40% of people will be experiencing sciatica at least one of their timeline, which is a big number, making it challenging to manage. So we have different patients. We come to our OPD with the condition of sciatica, and physiotherapists must be feeling challenging to manage it or treat it. So we'll discuss first of all the lumbar anatomy. There are 5 vertebrae in lumbar, which is L1, L2, L3, L4, L5, and which between there are discs from where the nerves, from front of that, the nerves are arising. So sciatica, there are five small nerves, L4 to S5 actually. They merge to form a sciatic nerve, which is the largest nerve of our body. Just above the knee, which splits in 2 branches, tibial and common peroneal. What we'll discuss is sciatica. Okay, so sciatica is caused by herniated disc. First of all, on herniated disc has 4 stages. What is herniated disc? We'll discuss that in here. Stage 1 is incomplete herniated disc, which is just a protrusion or bulging. Here we can see stage 1 is just a protrusion or bulging of disc. So in which the disc nucleus bulges but does not rupture. It does not rupture the disc. Okay, it remains contained with the disc structure. It keeps in the itself in a disc structure. The stage 2 is prolapse bulging. Okay, this nucleus is still contained botany, but the outermost fiber. Now it goes to outermost fiber in stage 2, which gives us back pain and leg pain. But stage 1 is back pain only. The patient will be presenting with back pain only, but in second stage, the nucleus will move out of, not move out, but it will touch the outermost fiber of the disc. Okay, in stage 3, there is extrusion. The extrusion, the disc nucleus escapes from the structure, but is still connected to the disc. It escapes from the structure of disc, but still in contact with the disc. You can see here at stage 3. Then we will find low back pain, leg pain, and hard neuro findings. We'll have some, tingling sensations and all of numbness, and the leg patient would come with these all of complaints. So stage 4 is the most severe stage, in which it is called sequestered. The fragments will be from both annulus and the nucleus escape from the disc. Here we can see it escapes from the disc. The nucleus escapes from the disc, the most severe kind of stage of herniated disc. So here is a small animation where we can see how the disc bulge herniation works. So this is our L4, L5 disc. When it protrudes out, this is nucleus, and this is the disc. So when it protrudes out, this is stage 3, touching the outer fibers. Stage 2, and then what does it do? When it herniates out, it disrupts the sciatica nerve. It disrupts the sciatica nerve. Another cause of disc herniation or sciatica nerve low back pain, it is called spinous stenosis. The first cause we discussed, which was the protrusion of the disc. The protrusion of the disc from the protrusion of the nucleus and protrusion of the disc out of its standard natural shape. Now we'll discuss some spinal stenosis. What is spinal stenosis? Spinal stenosis can also be called arthritis, maybe degenerative disc disease. It is basically spinal stenosis is the degeneration of disc. What does it do? Where, like we can see in the picture, there would be degeneration of the disc. The normal height of the disc would be degenerated, and when the disc is degenerated, the it will irritate the nerve behind it. So it will irritate the sciatica nerve, and it will give all this of the symptom we have discussed before. So what the common symptoms will see would be pain in standing or walking, will be relief in sitting. Why? We will discuss because of the some muscles also are linked with sciatica and low back pain. This is because of that. Also, the sciatica, it gets stretched in when you extend your hip and extend your leg. It gets stretched actually when you flex your hip and stretch your knee. So it gets relief in sitting, and stenosis and arthritis generally affect people of 50 or more older. That disease of disc herniation that can cause people younger, like maybe 30, or now we can see the people who are younger than 30 also can feel these symptoms. But now the stenosis is an old age disease. So with the assessment of sciatica, that would be, I would break this assessment. Whenever a patient will come to you, you may break the assessment into 3 categories. Either it will be myogenic assessment, or it will be neurogenic problem, or the problem would be because of orthogenic issue. What is myogenic? Myogenic is any problem in which muscles are involved or in provoking the pain or provoking the symptom. It is called myogenic problem. If you have a problem, like not taking the example of number, if you have a problem of any particular levator scapulae, it's a myogenic problem. But then again, if it disrupts the joint, it is called orthogenic problem. So the function of this assessment, aim of this assessment is not ruling out. We will see that in some cases there are 2 of these symptoms going parallelly, hand by hand. That we will see that in low back pain there would be sciatica, and there would be disruption in lower back pain muscles also. Both myogenic and orthogenic symptoms would be going hand by hand parallelly. Okay, so first we have to rule out if the problem is myogenic. We will palpate the muscle, we will have a certain test, so we can rule out if the problem is myogenic. Then we will see the nerve mobility. We will see assess if there is neurogenic symptoms, or we will see the condition of joint, how it is present there. If it has limitations, if it has laxity, if it is not presented normally, or with the lumbar spine, if it is in hyperlordosis or hypolordosis, that we can always check and assess in patient for it. So the main assessment now, the detailed assessment. What we will do, we'll first of all take the history from the patient. If patient comes to our OPD, we'll ask of question, the mechanism of injury. When did it start? How did it start? Okay. When did the neurological symptoms start? When did you find it that your lower back is not that strength? And then what did you find? That you start having the neurological symptom. You start having the tingling sensation. You start having the, any numbness in your foot. You start having the pain. So you have to, first of all, take the history of the patient, then observe the patient. Observe the patient when he comes to your clinic. In first of my internship, when I was in 3rd year of my clinics and 3rd year of my undergraduate degree, my clinical supervisor told me to always assess the patient when he walks into the clinic. What to assess? Assess his gait pattern. Look for any abnormal lateral pelvic shift. If his gait is fine, if his pelvic shift is fine, you can't tell if the pelvic is tilted anteriorly or posteriorly while the patient first comes to your OPD. You can tell by assessing it. But now, when patient is coming to your OPD, entering from the gate, you can see that if there is a lateral shift in, pelvis or not. Why to check it? We'll discuss it further in upcoming slides. Because of some muscles which are responsible for hiking the hip and laterally shifting the pelvis. We will also discuss it. Third, we will also assess the postural observation. We will meet patient, we will look for kyphosis. If the patient has kyphosis at his thoracic spine, if the patient has hyperlordosis in his lumbar spine, also we'll see if the patient has a scoliosis, and that's why he's presented by these sciatica symptoms. So we'll assess his spine and see for any symptoms. Then after that, we will see the nerve mobility. Also, I told you before that in neurogenic symptoms, we see if there is an involvement of nerve in it. So in observation and in history taking, we saw the questions that since when he is facing neurological symptoms. So you got to know, and the patient said, if he has the neurological system or not, you have to check the nerve mobility. You have to assess the neurodynamics. You know the stretches of sciatica, you know the stretches of other nerves passing that. You have to, check that how, maybe there is slump test for that, how mobile his nerve is. Okay, then there are functional tests we'll discuss later. There are MSK tests we'll discuss later. So what are the functional tests? We'll ask the patient to squat. If the patient is active and patient is athlete, sometimes the patient is, has a healthy ability of working out, we'll ask the patient to squat. And while he is squatting, we'll see the pelvic tilting during deep squatting. How does he tilt his pelvic during the deep squatting? We'll also see if there is any pain he feels during the movement. And then while he's doing the movement, we will check that which is the position, in which angle he feels the movement. Then we'll assess out according to that, being creative, that what is the problem, which muscles is responsible for that problem. Also, then we will assess the whole movement, whole position, whole movement, whole form of his squats, if he's doing wrong or if he's doing correct. So this is mostly for active individuals. Then we'll go for musculoskeletal test, which is Ober's test for IT band. We'll assess his IT band if it is working fine, if it has the full length. And we'll also, if it's tight, then it also can give some disruption in lower back and also can start spaining in lower back. We'll go for Thomas test for iliopsoas, hip flexors. We'll see if there is a problem in iliopsoas, then there must be, he would be feeling some anterior pelvic tilt or something like that. Then also we'll do rectus femoris test. What is rectus femoris? We will discuss it further. Why rectus femoris is important in this whole low back pain. We'll discuss it further. So now discussing musculature involved in low back pain. What are the musculature of lower back which is involved in, which gives the pain in back? So we'll discuss transversus abdominis, which is not again in lower back, but it's in the abdomen, but it also, the lower weakness of transversus abdominis can also give the lower back pain. Plus it is the multifidus. It's a long muscle going all the way from down, from up to down, the whole vertebra. Again, there is a muscle quadratus lumborum. Remember I told you that you have to see that the pelvic is shifted laterally. So the muscle is responsible for that as quadratus lumborum. Then again, we have to check for rectus femoris. Okay. Then again, we have to check for piriformis. This is the most important muscle in all of that. We will discuss it. So multifidus. So deep fibers of multifidus stabilize the spine before their movement occurs. So these are the dynamic and movement stabilizers, static stabilizers of the spine. As you can see, it covers the whole spine, and because of its tightness, it is the basic extensor of your spine. Because of its tightness, the whole spine can get tight. The whole back belt of muscles can get tight. So we have to check if the back pain, lower back pain, is because of the multifidus or what. And also there is a function written here: superficial fiber perform extension, side bending, and rotation from the spine. Because it has been like a guarding the spine actually. So anything happens to spine, anything happens to at the articular areas of spine, or anything happens to anywhere at your posterior belt, this multifidus gets into muscle gardening, which is for protecting the spine from any external stimulus or any external thing. So before going further in muscle, we have to see one thing, that this is the main root of muscle, weakness. Muscle weakness, muscle tightness, muscle spasm, then go muscle shortening. This is not always true, but in most cases, this is true, that muscle weakness is equal to muscle tightness. So patient comes to your OPD and he has the weak lower back muscles. You assess him, tight lower back muscles. You assess him, you give him stretches, you release those muscles. What does he do? He gets relief, he appreciates you, and he goes back to his normal life. But after going in, after he's going in his normal life, he will be performing some of those activities, some of those acts in which his lower back muscles would be again in stress. Why are they again in stress? Because his lower back muscles are weak. His lower back muscles are not capable of what he is putting the load on, what he is performing. So we have to check that what physical activity patient performs in his daily life, then we have to treat according to that. Otherwise, we will keep stretching it, we will keep releasing it. It will again come, the patient will again come to a physiotherapist, and he will blame physiotherapist because he has not treated him rightly. He'll ask the physiotherapist if he has not treated him rightly. So what we have to do, we have to understand that weakness is equal to tightness. His muscles are tight because his muscles are weak. His muscles are not capable of those activities he is performing. So the chronic tightness goes to spasm, not always, but yeah, it goes to spasm, but chronic spasm, it goes to the muscle shortness. Okay, so we have to check for the weakness, and we have to follow all of 2 phases of our treatment. I will tell you further later on. So going back to the lower back musculature, there is a muscle called transversus abdominis. It's not on lower back mainly, but it is the main muscle that stabilizes the spine during the movement. It is the main stabilizer which stabilizes the spine during the movement. It supports organs. It increases the intra-abdominal pressure, and also it is important for breathing and toileting. Many patients, many clients, many people who have a weak transversus abdominis can lead to low back pain because their posture, their control, their kinetic control is not right. Their dynamic stability of the spine is not right because they have weak transversus abdominis. Most of these patients have weak cardiovascular stamina. Again, this is also an important muscle which is called quadratus lumborum. Now, what is quadratus lumborum? Quadratus lumborum is present, like you can see here. And then what does it do? It laterally flexes the vertebral column. The side flexion, the lateral flexion of the trunk, the lateral flexion of the spine. So he does that. Also, what does it do? It extends the lumbar vertebra. The third responsibility of the spine is of the quadratus lumborum. It hikes and stabilizes the pelvic laterally. I would like to show you a simple movement. I like to on my video that then you will understand the word. Do I mean when I'm saying there is activity of quadratus lumborum? I would like to show you my screen if anyone can see my screen.
Doc, please, can you unmute your microphone? We can't hear you.
Sorry. So what does it do? This is the main function of quadratus lumborum. What does it do? It hikes your hip, extends your trunk, and this is also lateral flexion. So basically, when you do this, this is the activity of quadratus lumborum. In extension, I'm saying, in extension, when you laterally flex your spine, this is the activity of quadratus lumborum. So main activity is the hip hiking. The hip hiking quadratus lumborum does with the coordination of your tensor fascial lata and your IT band, because tensor fascial lata is also responsible for side flexion and hiking your hip. So what does it do? Hiking of hip, extension of your spine a little bit, and also lateral flexion. Now my quadratus lumborum is fully contracted. So my pelvis would be laterally shifted if there is any disruption or any tightening of quadratus lumborum of one side. It would be shifted on that way. That's why I said that it is important to rule out if there is involvement of quadratus lumborum or not. It is important to see if the patient has his spine laterally shifted or not. Okay, now again, going back to quadratus lumborum, here you can see it is. Then there is most important muscle, which is called rectus femoris. You all have known that rectus femoris is a muscle of quadriceps. What does it do? You must be wondering that a muscle in quadricep, muscle in anterior thigh, how can it contribute to low back pain? It can contribute to low back pain because of these reasons, that the origin of rectus femoris is from the iliacus. You can see it is the origin of rectus femoris muscle is from the anterior inferior iliac spine. Because of its origin from the pelvis, the tightness of it can generally pull the pelvis forward. Okay, it has the unique origin in pelvis. So when it pulls the pelvic forward, when it's tight, it pulls the pelvic forward, it disturbs the vertebral column. How it disturbs the angle of vertebral column? The tightness of one side, like if it is tight on one side, it pulls the pelvis forward, and while pulling the pelvis forward, for compensation, the extensors of other side of a person, of other limb, but posteriorly, they will compensate the movement and they will get tight, and they will form a movement which is called torsion in the spine. So we will see the patient has a different posture and different gait while walking. It will also contribute to low back pain or low back muscle tightness because of the compensatory movement when rectus femoris is tight. So there is the most important muscle of this whole. Every muscle is important, but the most important muscle of this discussion is piriformis. Why is this piriformis? The function of piriformis is to rotate the femur during the hip extension and abduct the femur. Just a second. Yes. And abduct the femur during the flexion of hip. Now, again, I would want to show you that what is the function of piriformis. So the basic function of piriformis, it is very deep muscle. First of all, we have to think that it's a very deep muscle. So what is the basic function of piriformis is it externally rotates the hip, and also it helps in extension of hip extension and external rotation. It's not the main prime mover, but it helps in that. And also it's a very small muscle, it's a deep muscle, so it gets tight always. So when I sit to stand, when I sit and when I stand, When I stand, it fires, it contracts. So always people with tight piriformis muscle will always complain that when they sit to stand, their pain starts in the lower hip, and it refers to down to the hamstring. I have observed that people with piriformis syndrome have tight hamstring. Tight hamstring leads to the tightness of, just a second. The tight piriformis will lead, the tight hamstring will lead to tightness in piriformis muscle, because the tightness hamstring will lead to the weak gluteus muscles. Then when gluteal muscles, because they are superficial, when they are weak, there has to be a compensatory action, which compensatory action is performed by piriformis, and piriformis is not capable of that load he is pushing in that way. So the piriformis muscle gets tight. So people always complain with the piriformis muscle syndrome when they sit to stand, their pain starts. And by seeing them, you will see they're very healthy patient. They have no symptoms of sciatica. Then right now we'll discuss what is it. We will also call this piriformis syndrome a pseudo sciatica. Pseudo means fake sciatica, because it fakes the symptoms of sciatica. And there is one reason for that, because sciatica is passing through, if you can see there, sciatica is passing through this piriformis muscle. So any tightness in musculature of piriformis or musculature of hamstring would make piriformis tight, and any tightness in piriformis would lead to faking the symptoms of sciatica. You can see. So patient will present with the symptoms of sciatica, pain at the level of hip and referring down to hamstring and sometimes calves. It is misdiagnosed and confused with sciatica because of similar symptoms, as I told you. So how to differentiate the diagnosis of sciatica and piriformis syndrome, means sciatica and pseudo sciatica? We can differentiate it. The pain of sciatica, sometimes, not every time, the pain of sciatica will go all the way from lumbar spine to the tip of the toe. The pain will radiate that way. The pain of piriformis syndrome would be start from the hip, and it would also refer to hamstring. Patient will tell you, patient will present with the complaint of that, doctor, my physiotherapist, I'm having this pain which starting from my hip and it's going down on my hamstring in the back of the knee. And when I get up, when I sit to stand, it inflates and it pains in there. And also sometimes we will see that there are tight calves. There is tightness in gastrocnemius and soleus muscle, even in piriformis syndrome. Then also it will again fake the symptoms of sciatica, but sciatica pain will go all the way to tip of the toe. Okay, so this is the main differential. This is not always true, but most of the time it is true that piriformis muscle pain would be starting from hip and going down in the back of the knee. It will end there mostly. What is the function of pelvic tilting contributing to low back pain? So there are two abnormal pelvic tilting, which is anterior pelvic tilting, which is most common in patients. It will be, as you can read, it would be forward tilt of the pelvis, resulting in increased lordosis of the lumbar spine and a protrusion of the abdomen. So again, as I told you, there would be weak lower back muscles, so they get tight, and also you will feel the tightness is lower back muscle and the shortening of lower back muscle at lumbar spine and a protrusion of abdomen. Again, I would like to show you the posture. With anterior pelvic tilt, what it will do, So like this, okay? In which we will see it present with the tight hip flexors and weak gluteal muscles. So the hip flexors are tight, means the ellipsois is tight, and weak gluteal muscle would be weak again. And what happens when gluteal muscles gets weak? All of its load comes to the deep muscles, which is the piriformis is one of the muscle, and there is a poor postural habit, which is of course. And there is a less common condition, which is posterior pelvic tilt. And as it's written here, that it takes a significant amount of tightness in hamstring or abdominalis combined to produce this postural distortion. Okay, so there should be a more tightness would be leading to posterior pelvic tilt, which is a short arc closed chain motion of the hip involved in pelvic. It rotates posteriorly, as anterior pelvic tilt rotates the pelvis anteriorly, posterior pelvic tilt rotates the pelvis posteriorly. So there is a tightness in abdominal muscles, or tightness is hamstring will pull the pelvis into posterior condition, or not small tightness. It would be needing a significant amount of tightness. Like here you can see, this is the fine posture, which is all of it is in line. But in anterior pelvic tilt, what does it do? It tilts your pelvic anteriorly. Why is it for forward head? Any condition in the spine, at any point of spine, it will correlate to other conditions also. It will disrupt the whole movement of spine. If we have scoliosis, we are prone to get sciatica. If we have kyphosis, we are prone to get lumbar lordosis, hyperlordosis. If we have lumbar lordosis, we are hyperlordosis, we are prone to have anterior pelvic tilt. So it all goes in correlation. If we have forward head posture, there is a big chance we will be having kyphosis also. When we have kyphosis, as I already told, we will be having a big chance of lumbar hyperlordosis. Okay. So what I say is every musculoskeletal treatment has two phases. Any patient which comes with the complaint of any musculoskeletal problem, you have to treat him in two phases. First is pain management. Second is strengthening and rehabilitation phase. Why are there two phases? So what physiotherapists you do in here? Patient comes to them, and I already discussed it. I'll discuss it again. When a patient comes to a physiotherapist in his OPD and it has his lower back muscles tight, it releases the lower back muscles, maybe myofascial release, do a manual therapy or anything, or any probe he uses. What does he do? He manages the pain. He releases the muscle. He does not guide him ergonomically. Also, he does not strengthen the muscles. Because his lower back muscles are weak, they will get tight again when he's again going home and performing his daily life activities, in which his lower back muscles will again get tight, and again he will come to you and blame you for that if you have not treated him rightfully. So what you have to do, if you have to counsel the patient, also guide the patient that the lack of pain is not the sign that you don't have an issue. There is a lack of pain because I've released those muscles, but again, they're going to get tight if we do not strengthen them the right way. If we do not rehabilitate them the right way. So these are two phases, and these also go hand by hand. There is nothing that the first 5 sessions would be pain management, another 6 session would be strengthening. You see? So they all would be go by hand. There should be pain management protocols in a session. Also, there will be some strengthening exercises, kinetic control exercises in a session also, in same session also. Okay. So I would like to share my protocol with you guys, that how do I start treating the patient. If a patient comes to my OPD, what do? I start with releasing the paraspinal muscles. with the patient of low back pain, with the patient of sciatica, there will always be tightness of paraspinal muscle. It could be multifidus, it could be rectus spinae. What I would do is I release the paraspinal muscles in his lumbar and thoracic region. And then what I do, I observe that any patient would have come to me with lower back pain or with sciatica who also has the tight myofascia, tight fascia at his posterior belt. What I would like to do, I would like to stretch and release the myofascia. The third, what I like to do is mobilize the pelvis. In every condition like this, when we have the lower back spasm, we will see the pelvis is not very mobile. Pelvis is lock. I would not say it's the right word, but it would be, jam. So what I like to do is I mobilize the pelvic passively and manually. And then I would like to perform neural glides. If there are neurological symptoms, I would like to perform some neural glides. I would like to test the mobility of the nerve, and then I modify the neural glides. How do I modify the neural glides? I would like to open my camera for that, making you understand. So, have you seen the slump test? Slump test is you have to, if this is my foot, if this is my leg, what I have to do is dorsiflex and flex the cervical. And this would be very painful condition for any patient with sciatica and irritation of sciatic nerve. This would be very, very painful. What I would like to do, if I would like to modify, I would like to modify the treatment. I would ask him to flex his cervical, flex his neck, and I would like to plantar flex. Ask him to plantar flex his foot. I'll go by that, this movement. If a patient feels relax in this, you can have a sign to go further. If a patient feels again irritation in this, you can again modify this movement. If this is my knee, what I would like to do is, see, observe my hand as it is your ankle. See? And then when he's feeling okay, when he's feeling all right, when his nerve mobility is enhanced, what you would ask him to do, if it's not that severe sciatica, what you would ask him to do, then you would ask him to flex his neck and go all the way like this. So his whole plexus, whole nerve is getting stretched now. Am I audible? So whole nerve is getting stretched now. So again, coming to neural glides, I will modify neural glides as I have told you. Then what I would like to do, which is very important in the treatment, in the first phase of treatment, it's opening the trunk rotation. As you know, that lumbar area of spine is responsible, vertebral joint is responsible for more movements, more rotation of spine, more mobility. It's not referred with the stability. It's less stable joints and more mobile joints. The main function of lumbar area is to be mobile, to move the spine. Okay, so move your upper area. So what do I like to do is like to mobilize the rotators, open the trunk rotator with the help of belt. I would like to open the trunk rotators, okay, so that he feels more mobile and the pain is reduced, the mobility is enhanced. Then what I like to do is spinal mobilization with leg movement. This is very important. I have seen and I have observed in my patient that spinal mobilization, when I mobilize my spine and I move his leg, research has shown that their symptom has reduced when I have included this in my session for long term. So this is SMWLM. I mobilize his spine. The therapist will mobilize his spine Another person will move his leg anteriorly and posteriorly, flexion and extension, flexion and extension. Okay. In this, there's our orthogenic component getting targeted. Secondly, the neurogenic component. This is also nerve glide, and this is also an orthogenic component getting targeted here. Then after all of that, what I would like to do is ask patient to move. After I have released his paraspinal muscles, after I have released his fascia, after I have opened his trunk rotation, after I have performed neural glides, modified neural glides, now I will ask patient to move. Why I will ask patient to move? But that there is a psychological reason that patient would always feel relief. When I have done all of these 3-4 things, patient will always feel relief. Okay. Then when a patient is moving, you will watch his gait meanwhile. If it is better than before when he was coming to your clinic, or it is the same, and you will ask him if he felt light, his answer will always be yes, that I felt right. The second phase is a strengthening phase. The first phase, you mobilize the patient, you did all of muscle releasing activities, protocols. Now there is second phase, which is called a strengthening phase. In a strengthening phase, we have to do these kind of things, which we have to perform kinetic control. We have to keep in check kinetic control. We have to do pelvic neutral training. We have to strengthening the extensors. We can do exercise modification in it. We can be creative about it. Physiotherapists can always think new ways of targeting the lower back muscles, which are basically the extensors. So we can do different experiments and exercise modification for targeting the extensors. Also, we can do the functional tasks. Okay, so here I would like to add a thing that if a patient comes to you, and again, I'll go to the assessment part, that if a patient comes to you, what you will do for assessing sciatica, for assessing his nerves, or for assessing the lower back pain, what you will do is there is a slump test to check the nerve mobility. You will ask him to flex his neck and ask him to extend his knee. But there is a more good assessment of sciatica or lower back pain. What you will ask him to do to see the limitations in the body, the limitations in the joint, the limitation in the range of motion, you will ask him to touch his toes. He will go touch his toes. Now you will see that how much range is there. Then we will ask him to extend. And you can do this passively also. So you have to see that how much range he can achieve actively, and then you will go passively and see if the extension is all right. If you will ask the patient if you feel any pain there, and then assess at what angle he feels the pain and where he feels the pain. Okay. Do you feel any pain? The patient will say, no, it's all right. Oh, yeah, I feel a little bit of stress here. Or it go like, feel any pain? Yeah, I have little tightness here. Tightness because of the contraction, stretch because of the tightness. Okay, stretch because of the tightness and shortening of muscle, or the muscle are in spasm. So also laterally flex. Yes, I have a pain there. There could be a difference in the range of both laterally flexion, both lateral, this flexion and this side flexion. The both side ranges could be different because of the involvement of quadratus lumborum. Also, must be any other reason. It could be multifidus who is not allowing the spine to move in one direction. Okay. Now again, coming back to our point. So from this functional ties, I remembered this, so I add this in the assessment. So what is kinetic control now? There is any uncontrolled movement, any type of uncontrolled movement can cause musculoskeletal issues. You must have seen that in gym, people are doing different exercises, or people are doing shoulder flexion. What they're doing, they're pushing their heavy weights. If this is, they're shaking their hand. Their hand is shaking like this. What does this mean? This means that they don't have movement control of movement they are performing, or that weight is much, you know, much heavier than they used to lift. Okay, heavier than their capacity. So there should be a control of movement, whatever movement they're performing. Basically deals with the dynamic stability. How are the stabilizers, and what are the stabilizers of lumbar spine are? The stabilizers of lumbar spine are quadratus lumborum. The stabilizer of lumbar spine are multifidus. The stabilizers of spine are transversus abdominis. So we have discussed about the pelvic tilting. So if a pelvic tilts anteriorly, then it's a problem. If a pelvic tilts posteriorly, then again it's a problem. So what does pelvic do? So pelvis, there is a basic pelvic tilt training, which we would ask patient to lie down on the ground, and you can also read there. Then his feet would be, his knees would be, or her knees would be 60 degrees in flexion, and I will ask patient to press his lower back against the ground while exhaling by tilting the waist pelvic backwards. Okay, as you can see. On inhaling, the patient then relaxes the lower back from the ground by tilting the waist forward. Okay, and we will ask her or him to move only the lumbar spine. Okay, and then once we can hold the basic tilt, you can progress and move and add the movement. And what movement could add to stabilize and the core and train the pelvis? This movement we can add. Pelvic tilt march. What is pelvic tilt march? So once you are engaged, once we have engaged our abs, our core, and tilted our pelvis. So again, the core is not only your abdominis, not only your rectus abdominis. The core is also your lower back muscles. Once you have engaged your abs and you tilted your pelvis, you will lift 1 foot up off the ground, bringing your knee in towards the chest. What we will do, it will lift up one leg towards the chest alternatively. Okay, make sure that you lift the leg in towards the chest, your lower back stays fully. So doing all that basic pelvic tilt, what we can add on it is a march, which is keep lifting the alternative legs, marching against all reps are complete. And this should be controlled march that you can speed up as you become confident in your ability to keep your lower back against the ground and your abs are braced. So this is for core stability, and the pelvis. The more your pelvis would be aligned, the more pelvis would be neutral, the more your core is trained. So again, the core is not only your core, rectus abdominis, it is also your lower back muscles. Okay. 2 mistakes for patients to avoid, that whenever the patient comes to us, they give us the 2 excuses that they keep ignoring the pain, that this is very common back pain, you should not worry about it, it will get better by itself. These are all excuses. My father also had this back pain, and someone in my family had that pain, back pain, and relief bells have, because someone had back pain and got relieved that it did that, even when he did nothing, doesn't mean that you have the same intensity of that pain. You have seen that there are multiple reasons of low back pain, multiple muscles contributing in low back pain, multiple components. It could be neurogenic, arthrogenic, or myogenic. So every individual is different. It is not the case that if a person gets relief with lower back pain by doing nothing, you will also get relief by that. So people have give this excuse that it's the weather, because it's the winter, I'm feeling low back pain. This is no excuse. Okay. So also what patients do, they try to patch it. They try to go to their general physician, which are not nothing against them, but some of them, what they do is they just a second. Okay. So what they do is they patch it. How they patch it? They use drugs. They use injections, corticosteroid injections. They use back braces. They use massages. They recommend for surgery. So these all, except surgery, these all things are treating the symptoms only. They're not treating the root cause. You understood? What a good physiotherapist will do would always, first of all, assess what the root cause is. What would be the root cause? It could be myogenic. It could be in myogenic. It could be different. It could be because of chordatus lumborum. It could be because of transversus abdominis. It could be because of multifidus. It could be because of rectus femoris. So after assessing the root cause, myogenic root cause, neurogenic root cause, it could be because of sciatica. It could be because of lumbar stenosis. So after assessing it, you then go to the treatment and all then perform the treatment which is right for the patient. Think creatively, okay? Again, mobility is the answer. The more patient will be mobile, as the responsibility of lumbar is mobility, more the patient will be mobile, the more there will be a mobility in pelvis, the more patient will be have enhanced mobility enhances the chances of recovery, enhances the chances of getting better at mobility, also at recovering the pain. So at the end of it, I would like to end my presentation now, and then I would like to appreciate if anyone has some question regarding therapeutics and regarding their low back muscles, or regarding the treatment I've told you. Thank you. I would like to, listen to your question. Hello. Hello.
Thank you very much, Doc. Ibrahim, am I audible to you?
Yeah, you are. You are.
Good.
Hello.
All right, so it's time for questions. If you do have any question, you can come out and ask so that doctor can address that for you. Okay, so we are still waiting for questions. So, Doc, my first question is that on the average, how long do
On
you
what, sorry?
spend? My
Okay.
first question is that on the average, how long do you spend in treating a patient? And on the average, do they report back to the clinic for the same symptoms? How frequent is that?
Okay. Okay. So when the patient comes to me, it differs. Basically, it differs individual to individual, and also it depends on what symptoms the patient is having, what problem the patient is having. Now, after assessing that problem, if it is myogenic problem, then I think it would take less time to heal and to recover with the physiotherapy, and as compared to if the patient is having the neurogenic symptoms, if the patient is having proper sciatica. In sciatica, the research says there would be 6 to 8 weeks of treatment. But when the patient comes to me with the lower back pain and maybe his lower back muscles are weak, I would like to treat him in probably most of the time 4 weeks. 4 weeks, in 4 weeks, with the frequency of session would be 3 days a week, sometimes 4 days a week, sometimes 2 days a week, depending on the condition of the patient, depending on the adaptation. There is a thing which is very important when treating a patient is the adaptability of treatment the patient's body is having. How much the patient's body is adopting the treatment, is adopting the exercise you are prescribing to the patient. It totally depends on that. So if the patient who is taking and adopting those exercises, his body is recovering very fast, which has a good health, good musculoskeletal health, then it will take almost 3 weeks to 4 weeks, 3 sessions a week. This would be the frequency, I would say. So it differs basically.
Okay, thank you very much for the answer. I think Victor has a question to ask. So Victor, if I'm audible to you, you can go ahead.
Sure.
All right. Thank you very much, Doctor, for your presentation. My question is, I want to know, are there contraindication or contraindicated activities that patient that comes to the clinic should avoid? Because most of the time, patient comes to the clinic and then when they go back, they will just continue with some activities that could be contraindicated to the treatment that he or she have received already.
Yeah. Exactly. Okay. I got your question. It's a very good question that we have discussed. That you have to address certain conditions. You have to address certain things when the patient comes to you, and this is not your duty just to release the pain, just to release the symptoms, just to release his lower back muscles. What you have to do is guide him about the ergonomics also. Understand what the daily life activity he's doing during what the nature of his job is. So what the contraindication also depends then what activity he is going to perform after he goes home. Okay, so when a patient he has severe sciatica, I will ask him, he has a herniated disc, I will ask him not to flex his spine so much, not to sit all the day. When a patient has some I can say multifidus issue, patient comes with the musculoskeletal low back pain, which is myogenic cause of low back pain, multifidus issue. I will ask him not to sit for longer hours. Well, I always say in my webinars when I address this issue that there is nothing like a bad posture. Any posture, the body is made to move. Any posture which you sustain for so long, it becomes bad for you. So any posture which you sustain for so long is contraindicated in any case. And plus in the multifidus issue, the muscular issue, I will ask him not to sit. And the sciatica, sciatica issue where there is disc bulge, herniated disc, I would ask him not to flex the spine so much, not to, I'll guide him how to squat when picking up something from the floor. Also, I'll guide him all about that, actually. Hope I've addressed your question, Victor.
Yeah, thank you very much. I appreciate it.
Thank you.
Okay, so I have a private message. You want to ask a question? You can go ahead if you can hear me. I don't know if I'm pronouncing it right, but that's straight.
Thank you. So please, I want to ask a follow-up question related to this particular question also. Normally, sometimes after a treatment with a patient, the next visit, the patient will give a comment like, after the treatment that day, I felt I was in so much pain. After the treatment, when I went home, I was in so much pain. I want to know, is it maybe I didn't do something right, or is just a normal response that can cause that? Thank you.
Okay. So what's your name?
I spelled it wrongly. Hysterics.
Okay. So brother, it's a very good question. I would like to answer it. I would like to rephrase it first. That what did you say that the patient that after you do the treatment, the patient complains that his pain gets aggravated and he does not felt that relief when you were aimed to give. Okay. So yes, most commonly patients do that complain. There could be multiple reasons for that. If you have done all of the things right, as I've told you, I have not mentioned any contraindicated treatment in whole this webinar. If you have done all the things right, there could be multiple reasons for this patient is complaining. First of all, the reason would be the the adaptability. If his muscles are tight, a person's body has adaptability of having these tight muscles. If you are releasing those muscles, the muscles would have the reaction towards it. Sometimes some of the patient's body
Hi, Doc. You are not audible now. We can hear you.
Am I audible now?
Yes,
am I audible
great.
now?
Yes,
Sorry,
please.
but there was a net connection. Okay, so if you have done all the things right, there would be a certain reaction. You have gone against the adaptability of that person's body. Okay, so person has adopted the shortness or the tight spasm or the tightness in his lower back muscles. When you treat it, you go for the spinal release, you go for the myofascial release. There would be a sign that something is going to happen. So one, it's muscle gardening. Second, it is the reaction of muscle. Third, it is there is after you do some manual therapy, you go for dry needling or something, there would be the soreness. The patient would ask after 2 days that the doctor, I feel some soreness in my muscles because you have targeted those muscles. Okay, those tight muscles you have targeted, so there is a natural reaction to those muscles, which the patient is feeling and complaining. So there is nothing like you have a physiotherapist has done wrong. There is a natural phenomena of muscles also. Hope I'm clear.
Yes, sir. Thank you.
Okay, so I have received a question to my DM. It says that, please, can you ask this question on my behalf? What is the differential diagnosis between sciatica and lumbar spondylosis with unilateral radiculopathy? Do I have to repeat the question?
Okay. No. I got the question. Okay, so I think the sciatica or lumbar radiculopathy, not always they're same. They're mostly they would present like a same thing with the same presentation, same pain going towards the leg, towards the toe. But sometimes it's not going towards the leg. Sciatica, as we told, as we discussed it before, we also saw the picture that the pain is going all the way, not all the way to the toe. It will go down to the leg, down to the hip, not all the way to the toe. So we have also to assess different things from here. The muscular element, also the orthogenic element mainly. So also we'll have to see the MRI. Sometimes the condition is how it is expressed in MRI, how we can see it in MRI. It's the patient is having severe degeneration, but the symptoms are telling you something different. The patient is not complaining something of that much pain, as there is no neural canal. There is no blockage of neural canal. The neural canal is fine, and the patient is having no complaint. So you do not have to 100% depend on the MRI for diagnosis, but you have to also make the assessment. Yes, MRI helps a lot in these cases, but you have to see the symptom and the presentation. You have to talk to the patient and then make your diagnosis on it. Also, then start your treatment protocol according to it.
Thank you for the answer to that question. We are still we have 3 minutes to receive few questions, and then we can end today's webinar. So is there any question?
Sure.
Okay, go ahead and ask your question.
Okay. So please, I want to just get a clarification. Normally, the sciatica and piriformis tightness normally have similar presentations. I want to know, is there something you can do different to, know the difference?
Yes. Yes. Okay. I got your question. So I've already discussed it during my presentation that pseudo-sciatica, which is piriformis syndrome, replicates or it fakes the symptoms of sciatica because the nerve sciatica impinges and it passes through this piriformis muscle, and when it gets tight, it impinges basically, and when it impinges, it fakes the symptom of sciatica. Also, the muscular pain would be referring, the sciatica pain would be radiating. Okay, the muscular pain, all not this not always true, but most of the time, the pseudo sciatica, the piriformis syndrome, patient will present like, patient will give the history, patient will tell you that he has the pain, starts from his hip and goes down to his hamstring, not below that, back of the knee, not below that. And sometimes he will ask, he will say to you that, my pain would go also in the calves, but not below that. But in sciatica, the pain will go all the way to the tip of the toe. Pain and numbness also, numbness, tingling sometimes. So there is a, there is no specific, but yeah, there is main difference is that also you can perform a musculoskeletal test. Also, you can check the neural mobility for ruling out the neurogenic involvement in it. Okay, so but the basic difference in presentation and the complaint would be the radiating and referring of pain. It would when it's piriformis syndrome, it would be pain would be referring, and it ends to the back of the knee. And in sciatica, it will always go to the tip of the toe. This is the main difference, but this is not true in all cases. So we have to perform certain tests, and we have to do an investigation if we have the doubt that this patient must be having some neurogenic issues.
Okay, thank you, sir. Follow-up question, sorry, if I'm permitted. So I want to know, can you perform sciatica exercises for a piriformis syndrome and still achieve some results?
Okay, so I'll answer that. So the rehabilitation phase, then when you say exercise, that's a strengthening phase now. So in a strengthening phase, in the rehabilitation phase, you always have to start training the muscle. Whose mic is disrupting? Can you please off your mic? So I'll get back to my question. Okay, so in any case, okay, so in any strengthening phase, what rehabilitation, what the aim of rehabilitation or training should be to rehabilitate that particular thing. That when I would like to give an example that in meniscus injury, the performance of meniscus, the responsibility of meniscus is to in knee joint. The responsibility of meniscus is to absorb the shock. And when we are rehabilitating meniscus, we have to gradually train meniscus for having the knee shocks. So the exercises for piriformis rehabilitation would be in the contraction and stretch of piriformis. Now we can become creative. Now we can think about it. How can we creatively modify the exercises and modify the stretch for it? There could be the same exercises as sciatica, but I have seen my clients who can with plates, but they still have piriformis syndrome. Why is this? Because the ratio of strength between the gluteus maximus and piriformis, between the hamstring and the piriformis, is not the natural, how the natural it should be. So what we do in there, it's an exercise of sciatica would not help him. The exercise of sciatica would not help the person who is athlete and is performing 150 kg squats, and he comes to us with a complaint of piriformis syndrome. Then we have to think about it, think critically what we can do in it. Then we will perform all of those exercises which target piriformis in isolation. Hope I have cleared the question.
Yes, sir. Yes, sir. Thank you.
Sorry. Yeah. Okay.
Okay, so I think we will take the last two questions that is in my DM. The first one says that
Okay.
what really causes what actually causes tight piriformis muscle? Is it due to prolonged sitting? And the second question is there any difference between Thomas test
Okay.
and straight leg raise test? All right. So these are the two questions.
Between what?
Is there any difference between Thomas test and straight leg raise test?
Okay. 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 So what was the first question?
First question is what actually causes tight piriformis muscle? Is it due to prolonged sitting? I mean, the causes of tight piriformis muscle.
Okay. Okay. So I'll tell you. So performance muscle could be, as I told you, that a person who's squatting 150 kg would be, as I told you, that could be anything. It could surprise you actually. How it can surprise you that, as I told you, that there is a quick fatigue. The other muscle which who is beneath it or who is contralaterally, it takes the weight of the responsibility of that muscle, and in compensating the other muscle, it also gets tight. So we have seen that in tight with the performance syndrome, we have also the tight hamstring many of the times. So if there's tight hamstring, the load of then we'll see the gluteus maximus is weak. The glutes muscles is weak. Then the all of the pressure and all of the load will go to piriformis muscle. As he is capable of, it is not capable of taking all the load. Also think that prolonged sitting can cause a piriformis syndrome also, because you are sitting, you're not walking, you're not training your glutes muscle, you're not training your glutes. Yes, by all long sitting, your glutes can be weak, and by weakness of glutes, your piriformis muscles can be tight. But it's not specific. It's not specific. There could be many causes for that.
Okay, thank you very much. We are just bringing the section to an end.
And what
we will appreciate your time, Doctor, for being with us. It's really an interesting section. I have personally learned a lot, and I believe that
Michael, there was one question, I guess, about Thomas test.
Yes. The last question was the difference between Thomas test and
about the second question. I forgot.
Okay, so the second question is the difference between Thomas test and straight leg raise. Yes, straight leg raise.
Yeah. So if you Thomas stress, it flexors actually most of the time. We see the tight legs, and in SL we see a number of things. First of all, we see the mobility number of things, but even in SLR, we do not we cannot specifically tell that it is because of lack of sciatic nerve mobility or something. It could be tight hamstring also. It could be tight something lower back also. So it is that it's not in any way, same flexors, Sorry.
Okay, that's great. Thanks very much for answering the questions for us. And, we are just wrapping down. We are just wrapping up on this section, and we want to appreciate your time for being with us. At least we've learned a lot, and we will plan subsequently to have few other sections with you. and we take it from there. I don't know if you have some few words to share before we close down the curtains. And before we do that, I want to use this opportunity to appreciate some of my lecturers in here. I don't want to mention names, but I'm really grateful to your support. It has been an amazing journey with you, and I pray that we will learn from you as well and move to the next stage in life. So Doc, we want to listen to your last words, and then we close down the curtain.
Yes. So I think, Michael, it's been great with all of you guys, and I would like that these sessions are very informative, and there should be a continuous chain of these sessions, so our physiotherapy community could serve their patients more, specifically, and the complaint that patients do, that they go to physiotherapists and they don't feel better, this complaint should be eliminated. And after all, ultimately, it's everyone goes to serve the physio community, the education. And I do like what Michael, you are doing for educational purposes, educating our physiotherapists, our chiropractors, and other practitioners. And I really appreciate you all for that. And I really appreciate you all for attending this session also, for the sake of good practice. Thank you so much for having me.
All right. Thank you very much. Please, if you've not subscribed to our channel, kindly do so by visiting YouTube, type Icona Health and Research Consult, and you click on the subscribe button. Thank you very much for coming. This is Icona Health and Research Consult. Have a blessed evening.